All right, let's start getting into the different types of aphasia. Before we get into different types of aphasia, let's review some older terms and maybe introduce some newer terms. To begin with, speech. Speech is how you move your mouth to produce phonemes that represent words, right? So, speech is your verbal production of language. It's not just your verbal production of sound, it's the sounds that represent words. Your language is the words within your speech or within your writing or that you hear or read. So, language is your use of words. And cognition is your attention, memory, problem solving, executive functioning, level of awareness, stuff we're going to get deeper into as we move through this semester. The term neologism refers to a meaningless string of phonemes produced by someone with aphasia. There can be portions of a real word within a neologism, I think greater than 50% non-word. It, it would be qualified as a neologism. So if I referred to this pen as a blicker pop, which some people with aphasia might very well do, then that is a neologism because because none of it is derived from a real word. So there is the general term paraphasia, and paraphasia refers to a language error produced by someone with aphasia. So another way of saying neologism is to call it a neologistic paraphasia. It's the same thing. So we have neologistic paraphasias, which are entirely made up jargon, non-word. There are phonemic, also known as literal paraphasia, and these are sound level errors produced by the person with aphasia. So if someone referred to this not as a can, but like a dan, so they had a sound level error, then that would be a phonemic paraphasia, also known as a literal paraphasia. Or if they added a phoneme, so instead of pen, if they said plen and added an L in there, once again, that's a sound level error produced by someone with aphasia. It would be a phonemic or a literal paraphasia. Now, a word level error is referred to as a semantic paraphasia. So an example of a semantic paraphasia would be me referring to this not as a can, but as a cup, for instance. Now, if I said cup, that's not exactly a cup, right? It's a can. But a cup is still a drinking implement, right? It's something you drink out of, just like a can. So it's related. It's not that far off, and it could still function for effective communication if the person with aphasia was pointing at it and saying, "Hand me the cup." You would understand that. So if the word that they errorfully produce is semantically related to the target word, we call that a semantically related paraphasia. But if an individual with aphasia produces a word that is unrelated to the target word, that's a semantically unrelated paraphasia, also known as an unrelated verbal paraphasia. And that would be like, instead of hand me the can, but hand me the car or hand me the dog. The word expressed is semantically unrelated to the target word, therefore, it's much less useful for effective communication. We have the word agrammatism here. Agrammatism is exactly what it sounds like. It is a lack of grammar. People with aphasia tend to have a lack of grammar within their language. So if you think back to your language classes, morphology is how words are put together with like prefixes and suffixes to convey different meanings, and syntax is how words are strung together to create appropriate sentences, and these two things sort of fall under the umbrella of appropriate grammar. So people with aphasia struggle with morphology and syntax. And in no small part, this is because of the next item: functor words and content words. Your functor words, also known as your function words, these are sort of the if, ands, and buts within sentences. These are the words in between the main words that convey the majority of the meaning. Those words that communicate the majority of the meaning are referred to as the content words. So people with aphasia struggle with having the appropriate functor words within their utterances. Oftentimes they're very good at producing content words, and a great deal of meaning is communicated within the content words. So it's possible for someone with aphasia to be an effective communicator, but still be very agrammatic. So if I were to give you the sentence, "It's a lot of fun being here," that has all the functor words and the content words. If I were to boil that down just to content words, I could just say, "Fun being here," and nod and smile, and the communication to you would be the same as the full utterance, although I've made it very agrammatic. People that have had strokes and now have aphasia usually have some form of preserved automatic language. And this is usually within the realm of rote, overlearned language. Some examples of what preserved language might be after stroke is reciting the days of the week, singing the happy birthday song. These are things that we always test in the context of an aphasia evaluation. We usually ask individuals to try to recite the months of the year as well, but that's a lot more difficult because you've recited the months of the year far fewer times in your life than you have recited the days of the week. So it's much less likely to be preserved. Depending on the level of religiosity of the person you're evaluating, you could try to elicit some church songs or Bible verses that may have been drilled into them at a very young age. I've had situations where I was able to elicit John 3:16 from stroke patients that really otherwise had no other preserved language. And I tried to elicit that simply because I knew what church they attended. And I knew that that had been probably drilled into them at a very young age. And it was going to be much more likely to be preserved than other forms of language. Also, curse words are often preserved. Words that are said more reflexively, more automatically, are often preserved. We have the term here, logorrhea, and this is when someone has basically nonstop verbal output. And receptive language is that language that you are receiving. You have auditory reception of language, which is the language that you hear and process. You have visual reception of language, which for most of us is reading. But that could also encompass if you're a sign language user and you're watching someone sign. Expressive language is us expressing our words. Most people primarily express themselves verbally via speech and in writing. So in this country, when you walk into a patient's room to evaluate their aphasia, you are always going to evaluate at least 4 primary modalities of language. I'll refer to these as the big 4. These are your 2 primary modalities of expression, your verbal expression and your written expression, and your 2 primary modalities of receptive language, auditory reception and reading, meaning your visual reception. Another word to go over is anomia. Anomia is word retrieval difficulty. So it's a lack of naming, anomia. You have trouble naming something. So you have trouble finding your words to express your thoughts. This is a core symptom of aphasia. Anyone that has aphasia is going to have some level of anomia. The best way for you, being a neurotypical individual, to understand anomia is to think of it, this is like when you have something on the tip of your tongue. You know the meaning that you want to communicate, but you can't think of the word to communicate the meaning. Now, we experience this tip of the tongue thing this is something we experience within the realm of normal. But if you take that and heighten it in severity to a pathological level, that's what aphasia is. There is a mild form of aphasia that is referred to as anomic aphasia. Anomic aphasia is different from the more general term anomia, which is displayed, like I said, by every person that has aphasia. And we usually test for the presence of anomia by simply giving a confrontational naming task, which is something as simple as, what's this? What's this? Right? And we present them with objects, pictures, and the tests for anomia within the more standardized tests start with more everyday objects, pictures of everyday objects, or presentation of everyday objects, and increases in difficulty by the presentation of less common objects. So I know, for instance, at the end of the Boston naming test, there's pictures that represent the words trellis and tripod and sphinx, right? These are far less common words, and they're going to be much more difficult for a person with aphasia and with anomia to find and produce. So if you have someone and you're testing them on anomia, if you show them a picture of a trellis and a sphinx, stethoscope, that's another one. If they're able to name those, then hey, that person is doing pretty good. So let me play a couple of videos to display for you sort of what an anomia is, and what I would say is probably an anomic aphasia.
Okay. So what's your name?
Scott. Oh, no. Sarah Scott.
That's right. And how old are you?
I can't.
Try.
I can't.
You're 19. 19. And what happened to you?
Stroke.
You had a stroke last year.
Yes.
And what happened? Can you remember what happened?
School and English class.
Okay.
And I book and I read it aloud. but I can't because stroke. And so I send that, and also it's the same as the same kind of thing as you know,
Pins and needles.
yeah,
Like pins
the
and
same, and also as well.
needles. Leg.
Yeah.
And what happened after the stroke with your speech?
Well, I can't.
You have speech problems.
Yeah.
Do you know what that's called?
Yeah. Aphasia.
Yeah, good.
All right, so what you'll notice about this video is she was understanding everything that was being said to her. She was, when the therapist asked her what happened to her, she was able to provide a pretty good narrative. School, English class, reading aloud, but can't because stroke, right? It's very agrammatic. There's like no functor words in there at all. There's no morphology really at all. And yet she's still a very good communicator. But of course, you see her constantly struggle to find the appropriate words. And that's what anomia is.
Hello? Okay, so this is our second video, and this is September. So it's June, July, August, September. It's about 16 months since you had a stroke. So last time I asked you what your name was and how old you are. So what's your name?
My name is Sarah Scott.
Good. And how old are you?
Oh, 18. No.
Do you want to write it down? Will that help?
No, I already.
18, 19.
20.
Hooray. Yes, you're 20. You had your birthday the other week, so you haven't been 20 very long. And what have you been doing today?
Riding. But instead of Wednesday, it's Monday, Tuesday.
That's right, going on a different day.
Yeah, and it's
One of the things I want you to notice about this particular video is when she's trying to find the word for what day it is, she backs up to the beginning of how you would recite the days of the week: Monday, Tuesday, Wednesday, right? And she works forward and finds the word. So that's a form of self-cueing. And if the patient has gotten to the point where they're able to self-cue, even if they can't find the word outright, if they have a strategy to get to the word, or if you have taught them a strategy to get to the correct word, then that's very valuable language strategy. And it also shows appropriate cognition and forethought and troubleshooting, problem solving. So basically, the study of neurology really took off in 1861 when the doctor, Paul Broca, identified that it is this inferior posterior section of the left frontal lobe where a person's expressive language is primarily housed. And not long after that, Carl Wernicke was able to localize receptive language in the temporal lobe of the left hemisphere. And they did this by essentially they had stroke patients that had lost their language, and then when that person died, they did an autopsy and they saw like a big lesion right at what we now call Broca's area. And they're like, well, this guy really had no language whatsoever. So that part of the brain probably was responsible for his expressive language. And this was also a period of time where everyone had awesome facial hair. Apparent. And these two guys pretty much started a trend in neurology of what we refer to as lesion localization. And that is being able to look at the behavior or the deficits of a person and being able to predict from their deficits where the lesion is in their brain. Now, this works easily for language, which is why language was sort of the first thing that was studied so in depth and for so long during this period of time when there really wasn't the technology to study the brain in any other way. But one thing to recognize about lesion localization, and I have it right here, down here at the bottom, which is that you can look at the speech or language of someone and you can predict where their lesion was. Their lesion is in their brain. But you can't look at someone with a lesion and reliably predict what the outcomes are going to be. All right, so let's review the zone of language. The zone of language is this medial lateral portion of the left hemisphere that encompasses all your primary language areas, like Broca's. And Broca's area is that part of your brain that takes the meaning that you want to express and finds the words for you to express that meaning, be it verbally or in writing or in Morse code, however you want to express that language. Broca's is the part of your brain that finds the words that allows that expressive language to happen. Also, we have Wernicke's area at the superior posterior part of the left temporal lobe. Wernicke's is that part of your brain, that part of the zone of language that receives the speech sounds that you hear and interprets and derives words from the speech of others. And there is the angular gyrus that is just superior posterior to Wernicke's area. And what Wernicke's area is to auditory reception of language, the angular gyrus is to visual reception of language. So the angular gyrus is that part of the zone of language that receives signals from your occipital lobes about the letters that you're seeing on the page. The angular gyrus allows you to derive words from the letters that your eyes are seeing on the page. So whereas Wernicke's area takes those speech sounds and allows you to derive words, receptive language from those speech sounds, the angular gyrus allows you to derive words from those squiggles that you see on the page. And running between these posterior language areas of reception and your anterior language area, Broca's area, is a band of white matter tracts that is known as the arcuate fasciculus. And the arcuate fasciculus is important in that it allows words that are processed and interpreted by Wernicke's area to then be transmitted anteriorly to Broca's for you to express. In short, it allows you to repeat exactly what you hear word for word. And it allows you to transmit words that you read that are processed at the angular gyrus to Broca's for expression. In short, it allows you to speak the words verbatim that you're reading. In other words, it allows you to read aloud. So before we walk through the different profiles of aphasia, let's do a quick walkthrough here with how these different aphasias acquire their primary characteristics. So let's say someone has a stroke right here. Just clipping Broca's area, anterior to Broca's area, but leaving vernix area intact, leaving the arcuate fasciculus running between vernix area and Broca's area intact. What are the deficits going to be? Obviously, this guy is going to have trouble finding his words. He's going to have some expressive language deficits. But he's still going to be able to understand most of what is said to him because vernix area is intact. And the arcuate fasciculus is still connecting vernix area to Broca's area, so his repetition of what he hears is still going to be pretty good. This is transcortical motor aphasia. Let's say we have a bigger, more serious stroke. Takes out most of Broca's, and it knocks out, it damages the arcuate fasciculus like this. So now, what are the deficits going to be? Well, he's still going to be able to understand most of what's being said to him because vernix area is intact. But the arcuate fasciculus is now damaged here where it connects to Broca's. So repetition is going to be impaired. And Broca's area has been damaged significantly. So he's going to have significant expressive language deficits on top of that. That would be a Broca's style aphasia. Now let's say we give this guy a lesion on the anterior side of vernix area. It's damaged vernix area, but it hasn't damaged the connections between vernix area, the arcuate fasciculus, and the arcuate fasciculus and Broca's area. So what is this individual going to look like? Well, he's going to have difficulty understanding what's said to him. He's going to have receptive language deficits. His repetition is going to be pretty good because the arcuate fasciculus is intact. And he's going to be producing verbal language like nobody's business. So this would be transcortical sensory aphasia. Any aphasia that has the word transcortical in it, that means repetition is preserved. But if we give this guy a much bigger lesion, more significantly damaging the arcuate fasciculus, what's he going to look like? Definitely, he's going to have receptive language deficits. He's going to have difficulty understanding what people say to him. Repetition is going to be much more impaired because the arcuate fasciculus is impaired, but Broca's area is intact, so he's going to be presenting lots of verbal language, logorrhea. And this would be a vernix style aphasia. Now, if we had a stroke that was large enough and damages the entire zone of language, this person is going to have a global aphasia. There's going to be little to no verbal expression, little to no receptive language, little to no repetition. This person is pretty much going to be reduced down to the level of using gesture. And they'll only be able to gesture using their left hand because their right hand is controlled by the left hemisphere, and the left hemisphere, especially the left frontal lobe, has suffered a lot of damage. So you're going to have that contralateral hemiplegia. So that's global aphasia. So this is a quick run through where I'm showing you the lesion sites and how they produce your primary areas of deficit for each major aphasia type. Okay, so now slowing down and going through, getting more into the weeds. We have two primary categories of aphasia. So when you think about aphasia, we tend to think of them as being either non-fluent aphasias or fluent aphasias. And I will also use the term expressive aphasia to refer to a non-fluent aphasia, and a receptive aphasia to refer to a fluent aphasia. So non-fluent aphasia, because these individuals are very non-fluent. They have expressive language deficits, but also refer to them as expressive aphasias because of the expressive deficits. Fluent aphasias, we use that term because these individuals with aphasia are very fluent in their verbal output. And also may use the term, like I said, receptive aphasia, and this is referencing their primary receptive language deficits. Our three classic categories of non-fluent aphasia are Broca's aphasia, transcortical motor, and global. All right, so one important aspect to recognize about the non-fluent aphasias is that they're all non-fluent because the left frontal lobe has been damaged to some degree. And that's where a lot of your motor areas are, especially motor structures and areas that are responsible for allowing you to control the contralateral side of your body. So your people with non-fluent aphasia are going to have a contralateral hemiplegia. So if they're walking, they're going to be walking like this with a walker and a spastic right arm. If they're not walking, they're going to be in a wheelchair, and you're going to see the same physical deficits. The contralateral hemiplegia from the damage to the frontal left hemisphere, the left frontal lobe, that's going to create really contralateral spasticity from basically here down. So that is going to affect the right side of your articulators, creating a dysarthria, unilateral upper motor neuron dysarthria. There's a good chance you're going to have some apraxia of speech in there. And the contralateral side of your tongue, your pharynx, and your larynx is affected as well. So there's a good chance you're going to have these individuals will have swallowing deficits as well. So your guys with non-fluent aphasias, when you first see them, you're really going to be trying to figure out what is the most severe problem that you need to address first. Because there's a good chance they're going to have their aphasia, their non-fluent aphasia, and there's a good chance they're going to have some motor speech deficit, probably unilateral upper motor neuron dysarthria, if not having that plus apraxia of speech. And they're also probably going to be having some swallowing deficits as well. They're also probably going to be having some cognitive deficits as well because one of their frontal lobes is damaged. So your non-fluent aphasia aphasia guys, we see them for lots of different deficits. So let's start with Broca's aphasia. As I've already mentioned, Broca's aphasia is the result of a significant lesion at or around Broca's area. And it's usually due to an occlusion, so a stroke, among the anterior branches of the left middle cerebral artery that are responsible for supplying freshly oxygenated blood to Broca's area. And a lot of the people that you see with aphasia, they're going to present the next day, the day after their stroke. They're going to present as a more severe aphasia, like global aphasia, like Broca's aphasia. But they're going to quickly recover, and their aphasia, their category, their type of aphasia will evolve as their deficits change. It requires a pretty big lesion to produce a lasting Broca's aphasia. These individuals tend to be good communicators, like you saw in the video there with Sarah Scott, but they tend to be poor speakers in that they're usually missing lots of words. They're very agrammatic, but their use of the words they have, their use of facial expression, prosody, body language is still very good. So they can be very good communicators. So your guys with Broca's aphasia, they're going to have very non-fluent speech. You're going to know that the minute you walk into their hospital room. But they're going to have pretty good auditory comprehension, functional auditory comprehension. They're going to have poor repetition because, like we said, the arcuate fasciculus has been damaged. So their primary problem is a significant to profound anomia that is going to create very disfluent speech for them. So when I say disfluent, I'm talking about an MLU of 0 to 5. In 5, like if someone with Broca's aphasia produced a 5-word utterance, you'd probably fall out of your chair. So it's more likely to say your person with Broca's aphasia, the MLU is more like 2 words, 3 words maybe. And as we've already said, these are mostly content words. Usually functor words are completely absent. They have a great deal of phonemic paraphasias, meaning sound level errors in their speech. Your guys with Broca's aphasia, they are very much aware of their deficits. They're very much aware of everything that has happened to them and everything that they have lost. So these are your guys with aphasia that tend to be very upset. They can be very emotionally volatile because they have been through a lot. And now you're walking in there and you're trying to get them to do stuff. So you have to sort of help them work. You have to help them manage their emotional struggles enough to participate in therapy. But the good side of that is that they know what's happened to them. And these are the guys that are going to fight to get better. So these are your fighters. They tend to have a lot of perseverations, meaning this is a word or a phrase that they produce again and again unknowingly, or perhaps they think they're saying one word and the word that they're perseverating on just keeps coming out. And people can be aware of their perseverations or completely unaware of their perseverations. These guys are often going to have some low level of preserved automatic language. So counting 1 to 10, they're usually able to do that. They might get to 11, they might get to 12, and long shot 13, but after 13, they almost universally fall apart. They may be able to say the days of the week. They're usually able to sing the happy birthday song with some assistance. And as it says here, as I've already said, expletives, they usually have some preserved curse words. As I already said, they're going to have that contralateral hemiplegia, which is, there's a good chance it's going to affect speech and swallowing as well as gross motor movement, putting them in a wheelchair. And because the inferior posterior portion of the left hemisphere is damaged, there's a good chance they're going to have apraxia of speech as well. So here's an interesting guy with Broca's aphasia. This is not a typical presentation of Broca's, but it's a good presentation of perseveration.
This patient is at manipulating his intonation of this utterance. The segments you will see are, first, a conversation about his upcoming move to a new house, followed next by a sample of his spontaneous automatic speech. Now tell me, why is it that you're moving, actually?
Tunnel.
Is it because the kids have grown and the house is getting too big, or ready for a smaller place? Seems reasonable. Let's to keep up.
All your children are grown, right? How many children do you have? Can you count that out for me? What number is this? Right? Now let's count it out.
1, 2, 3, 4.
Nice. Since you did 4 so well, let's go for broke. Let's go up to 20.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 1, 2,
All right, so that's a good example of a guy using his perseveration pretty effectively. So basically, what he's doing, he's taking his perseveration, tono, 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 but he is basically just saying it over and over and putting a normal prosody along with it. So he's communicating via prosody, facial expression, and body language, and you see that they're able to maintain a somewhat normal conversation. Also, there at the end, you see a pretty dramatic example of preserved language.
Now tell me what this thing was with your legs last week or week before.
No good. Ache and knees and ankles.
What'd you do about it?
Home, doctor, and legs. Walking, no good.
No good, huh? Man, you're a fellow who likes to walk.
Oh, jeez. Oh, boy, oh, boy.
But what I want you to notice about this recording is, first of all, the individual's deficits. He's very non-fluent. He's struggling to communicate. But the few words that he is able to find is very much laden with meaning. I also want you to notice how they were having essentially this conversation. It was a slow conversation, but it was communication going back and forth. How was that able to happen given that this guy has such severe aphasia? If you watch the clinician, he is sitting back, he is giving this patient what is essentially oceans of time to respond to his questions. And it's not something that you're going to do all the time in therapy, but you need to be able to go into the mode where you are enabling effective communication to happen between you and the individual with aphasia. And a large part of that is allowing them large amounts of time. The average speaker, asking a question to someone else, gives that someone else between 1 to 2 seconds to respond appropriately before that person that asked the question starts getting really anxious about the situation.